Hello, I'm Kathryn Villarreal, and this is a reflection on my practicum experience and the development of my capstone project. My focus is on a subject near and dear to my family's heart. It is a patient population my grandfather falls into, elderly Hispanics with dementia. Cognitive decline is often brushed off as a normal part of aging. However, dementia, along with other forms of cognitive decline, is a treatable or at least manageable condition. As life expectancies continue to rise, dementia rates are expected to do the same. In 2014, there were 5 million adults in the U.S. diagnosed with dementia. Latinos are 1.5 times more likely to have significant memory loss than their Caucasian counterparts, and Latinos with Alzheimer's are predicted to double by 2030. I have chosen to write my paper about people living with dementia because it has affected my family. My grandfather is 89 years old, immigrated to the U.S. from Torreon, Mexico, while he was raising a young family and made a living repairing record players in central LA. He was a patriarch. As a patriarch, he has always been given the ultimate respect from his 6 kids and 14 grandchildren. He has always been a man to overcome great struggle, which I hope he is able to do again with this fairly new diagnosis. There are 2 major challenges caregivers of people with dementia tend to face, which I've seen in my aunt and my grandmother, which is behavioral challenges and physical care. My grandfather doesn't understand why traffic signs outside are written in English, gets enraged when he's told he can't drive or is offered help in the shower, and sometimes he confuses his wife with his mother. My family and much of the Latino community relies on meditation and prayer when faced with such challenges. The development of my capstone project originated by thinking about what I wished the nurses knew about my grandfather when he was admitted to the hospital for a UTI. I considered what I have seen in my own 7 years of caregiving experience between the person with dementia, the nurse, and the family. I talked with my family about what works best for my grandfather and what does not. I also considered cultural differences like religion and gender roles. Lastly, I thought about what resources were available to my family and which they were using or not and why. I wanted to greatly humanize my grandfather, making him more than an angry old man in the hospital employees likely saw him as. And if I'm being honest, I've also seen while working when I haven't gotten enough sleep and I cannot get my patients to stop yelling at me. My original big idea wanted to shed light on cultural differences, the pathophysiology of dementia, factors like machismo, and the unique stories and traumas of immigrants. I took all these grand ideas and boiled them down to one effective, measurable, attainable idea: in language. Something more powerful than the scalpel, more important than medication, something that supports the entire hospital system at making patients better, as it allows a patient to define what better is to them. I have heard how interpreters have failed my family, and I've seen how inconvenient they are to use at my workplace. So for my project idea, I decided to focus on better, more accessible interpreters for patients. I called my family to share my idea with them, and my family's reaction to my idea to bring more interpreters to the hospitals was not what I was expecting. They liked the idea of having more bilingual doctors, but did not seem impressed with the idea of having more interpreters. I think this is because of their limited experience in the hospital, as it was in the early days of COVID, and they could not visit my grandfather often, and not fully understanding what a struggle it would be to communicate with a Spanish-speaking person if a bilingual caregiver was not there. They stated it is always best to speak directly with the doctor, that interpreters were nice, but sometimes it made the room feel crowded and noisy, and sometimes they didn't think the interpretation was accurate. My aunt also said it was hard to focus on the doctor when the interpreter was speaking. Unfortunately, my grandfather's dementia is too far progressed to ask him about this project, but my aunt said he seems to do okay with the interpreter. I talked with my other family members several times to discuss this project, each time for about 3 hours. I have in my records we spoke April 3rd, August 18th, and October 10th, but we speak regularly, and there were other times we spoke about what is new in some subjects. And there were times we spoke about what's new in their lives, and some subjects overlapped with this project. We spoke on the phone because we live in different states. One of the stories they shared with me was how long it took to get an interpreter when they first arrived at the hospital, which helped inspire this project. My grandmother had told me it wasn't until they were able to understand her explain how differently he had been acting the providers understood what was going on. Although my capstone idea is mostly applicable to hospitals and hospital unit action, my family did have a few takeaways from the discussion. They have a better understanding why a professional interpreter might do a better job of explaining complex medical terms, and for that reason, my grandmother has a legal right to the interpreter. My family understands that although at times it seems easier to interpret themselves, using a professional interpreter will increase quality of care and decrease chances of error. For these reasons, they have promised me to insist on getting an interpreter if they ever find themselves in a similar situation again. One question for the intervention feedback form is, did your family need instruction? For a simple intervention like asking for an interpreter, I would say they didn't need instruction, more words of encouragement. I told them that they are their own greatest advocate, and in other words, the squeaky wheel gets the oil. This intervention can be measured with a scale rating overall patient satisfaction. My family could keep track of how often they were given an interpreter and how satisfied they were with it. And from a hospital perspective, we have a quality inspector interview patients before they discharge, where they have questions about hospital stay to monitor quality of care and patient satisfaction. That would be a great time to ask some follow-up questions about the patient's experience with the interpreter. The hospital and hospital unit action I was referring to is I will be bringing it up at my next unit-based council meeting, an idea which has two parts. One, to supply my brochure to the unit to educate on the importance of using an interpreter, and two, to brainstorm and push forward a plan to get more video and phone interpreters on our unit, and possibly in person as well. There is undeniable evidence that interpreters improve quality of life. 1 in 40 malpractice claims are related to failure to provide interpreter services. Interpreters have also cut down on unnecessary appointments and tests, saving time and money. One study that looked at almost 2,000 Spanish-speaking families with limited English proficiency found greater levels of satisfaction with cares and shorter time in emergency department. They also found in-person interpreters shortened time admitted. Interpreters decrease unnecessary interventions, ensure proper patient teaching has occurred, and even better diagnose physical and mental conditions in people with limited English proficiency. Benefits of using a professional interpreter include fewer errors, increased patient satisfaction, they can act as a cultural liaison, lower malpractice risk, shorten hospital stays, and lower risk for hospital readmission. And lastly, it fills a requirement of the Title VI of the Civil Rights Act. There is peer-reviewed literature that explains how interpreters are best implemented. Although interpreter use is associated with greater patient satisfaction, healthcare access, and communication, interpreter use is less utilized in the emergency department. According to literature, hawk interpreters, like family, friends, and untrained staff, are more likely to miscommunicate and breach HIPAA. Other issues include children struggle with interpreting adult issues, families may have personal agendas or provide unsolicited advice, and may misunderstand medical terminology. Using hawk interpreters are associated with longer hospital admissions, and children should never be used to interpret except for emergencies. To use an interpreter, the provider should address the patient directly while the interpreter is next to the patient. The conversation needs to be clear and direct by keeping statements short with time to interpret in between them. Providers should always utilize the teach-back method, especially with those with limited English proficiency, so that they can be sure their patient teaching was effective. Obviously, technology can be utilized to improve interpreting. We use interpreting technology at my work, which is helpful but not perfect. At my work, we have an iPad mounted on a rolling stand in a closet down the hall, shared with 2 other units, and it takes a long time to grab, log in, set up, then put away for each patient interaction. When observing my own workplace and discussing this issue with my colleagues, there were some patterns and barriers to using the interpretive services. At my hospital, the most frequent complaint was the interpreter takes too long to set up. For small cares, sometimes it doesn't seem realistic to use the iPad interpreter every time. Another barrier to using the iPad is not as clear of a voice. For patients who are confused or hard of hearing, the iPad can be hard to understand and is too quiet, but they are more cost effective and can cut down on time. Instead of one iPad with the interpreter application in it, let's have multiple. I know what a time saver it would be to keep the interpreter device in the patient's room instead of returning it down to the hall each time. My unit has an extra iPad we keep for entertainment for the patients. A great way to improve the system that would be to have the interpreter services available on there too. That way, depending on our unit's needs, we can use the second device for entertainment or interpreting. I believe this is the most cost-effective solution. However, I do think it is important to discuss the use of in-person interpreters. In-person interpreters are paid by the hour versus phone and video, which is paid by the minute, so they are more expensive. However, they can be a really valuable asset to hospitals that serve a large Hispanic community. I know on my unit alone in Portland, Oregon, we have at least one Spanish-speaking patient a month. That is not considering the rest of the hospital's needs. I endorse having an in-person interpreter on call or in-house to serve those patients who cannot use over the phone or video interpreting. Here are the pros and cons to both in-person and online or phone interpreters. According to recent literature, here are some findings providers might consider when choosing what type of interpreter to use with the patient. In-person interpreters are easier to hear and communicate with as a provider and the patient. They're also generally less confusing to talk to, especially for patients who are in an altered mental state. However, some patients are uncomfortable speaking with an interpreter in person because it feels more like a breach in privacy. Video or phone interpreters can be more readily available, especially when a patient first comes to the hospital, and are more cost effective. However, the video and phone interpreters I've used at times feel choppy and are not loud enough for someone with poor hearing. As technology advances, online interpreters will become more user-friendly, but until then, all three options should be available, as any type of interpretation has been shown to be greatly beneficial. There are several national and state policies that regulate the use of interpreters and diverse hiring practices. The Civil Rights Act of 1964 and Executive Order 13166 requires federally funded healthcare institutions to have interpreters. Where I work in Oregon, a new law signed in 2022 makes it mandatory for healthcare providers who are publicly funded to use certified healthcare interpreters. When the provider is proficient in the preferred language, the patient has their own preferred interpreter, or no interpreters are available. These are the exceptions to this mandate. Per the law stating we must provide an interpreter, providing someone a video or phone interpreter which they cannot hear or understand, I argue does not fulfill their legal right, once again pushing for the argument of using in-person interpreters. Title VII of the Civil Rights Act in 1964 prohibits employment discrimination based on race, color, sex, religion, and national origin, and is enforced by the Department of Justice. According to the American Association of Colleges of Nursing, there is a high need for nurses from the underrepresented African American, Hispanic, Asian, American Indian, and Alaskan Native groups, as these make up over a third of the U.S. population. However, these groups only make up 19.2% of registered nurses. I want to talk about the long-term solution for language and cultural barriers in healthcare, even though it is not a part of my intervention. I still think it is important to note we need to continue to improve bringing minorities to careers in the health and sciences. Since 2019, the number of students pursuing baccalaureate and master's programs in healthcare has grown, but there's still room for improvement. According to the AACN's 2017 survey, only 16% of full-time nursing school faculty are from a minority group. In 2018, AACN partnered with the National Institute of Health to implement mini grants towards the All of Us research program, which funds schools in underfunded communities and increases awareness. The AACN also gives to the Nursing Workforce Diversity Grants, which increases nursing education opportunities for minorities. Lastly, you can find scholarships for minorities at nursejournal.org. The baccalaureate prepared nurse has a role in policy implementation and development. They understand the importance of staying up to date in new research, evidence-based practice, and policy. It is our responsibility to uphold hospital policy and the law in our practice. Furthermore, we, in upholding these standards and reporting our findings, can contribute to the progress of healthcare sciences and quality of practice. For instance, in my hospital, we have a Datix program. This is a web form we go to report mistakes and near misses. This information is processed and often led to corrective action, which comes learning, change, and progress. My capstone project surprised me in some ways. I thought the idea around this project were going to be easier to implement. I also thought in-person interpreters were going to be the total best solution. However, studies show mixed results and even sometimes side with video and phone interpreting. I also thought my family would be more enthused by the idea, but they came off unimpressed. I attribute this to the fact I don't think they fully realized the other issues they had that were seemingly unrelated to not have an interpreter were more connected than they realized, like my grandfather not getting showered and being really upset during his hospital admission. My expectations were exceeded with how much data there was on interpreting. There was information on the use of different kinds of interpreters in different units of the hospital and different aspects of care for different kinds of patients, and I'm happy to see such inclusive studies. However, I wish I found more information about patients who can't use video or phone interpreters. In my own experiences, patients who are hard of hearing or are more confused had a very difficult time using this type of interpreter, and many times we often had to use an unofficial bilingual caregiver, which performed better. This situation was not described in the literature I found. I also could not find any literature on how to set up an interpreter services in the healthcare setting. For instance, I didn't read any suggestions on how many interpreter devices should be on a unit, which would give insight to the issue we're having at my own workplace. I believe my plan can be adopted as best practice practically, to some degree. Already, we are finding out if the interpreter program can be downloaded on the other iPad, the one that belongs to our unit only, but we need some administrative support and passwords to complete this process. However, it will take a lot more time to get in-person interpreters to the hospital. What's great about this intervention, although originally it's made for Spanish-speaking patients in the US, it's very generalizable. This idea can be used in many states and communities with large Spanish-speaking communities, but because phone and video interpreters have access to so many languages, all people with limited English proficiency would benefit. In fact, more accessible interpreters would help healthcare settings globally. I hope you enjoyed my presentation and learning about my family and background. I have thought about my passions and what issues I've seen professionally and personally, and I'm proud to be advocating for an underrepresented minority. Through these courses, I have learned to appreciate the art of looking up new data. It has reminded me healthcare is a science and ever-changing, not stagnant policies. Thank you for your time.